Shared healthcare resources, ICU beds, blood supply, ventilators, are assumed to distribute risk efficiently. The assumption is that pooling absorbs individual patient demand. No single patient exhausts the system because the system holds capacity for all. This logic is locally valid under normal demand. It does not extend to the pool itself under surge conditions. Pooling averages demand fluctuations across the patient population. It redistributes resource burden across time and across units. It does not reduce total demand placed on the system. The aggregate number of patients requiring care is unchanged. Only the distribution of who is served when changes. Total demand is preserved. Pooling eliminates individual resource failure at the cost of collective exposure. Absorption is displaced from individual patients to the resource pool itself. If the pool can be exhausted under surge demand, pool failure becomes the relevant absorbing state. Once the ICU is at capacity, individual patients are no longer protected by the existence of the pool. The hospital resource pool has finite capacity. Once that capacity is exhausted, collapse affects all incoming patients simultaneously. Pandemic surge conditions exhaust ICU beds, ventilators, and clinical staff at once. Absorbing thresholds exist at the pool level even when individual cases appear independent on admission. Independent patient cases share pool-level exposure once they compete for the same shared resource structure. The pool inherits the extreme demand of each component. Flu season and COVID surges activate high-acuity demand simultaneously. Aggregation does not reduce extreme resource pressure. It concentrates it in the shared pool. Pooled healthcare resources accumulate risk under sustained demand. Each period of high utilization draws down the same finite reserve of capacity. Structural limits of pooling become visible only when the pool approaches exhaustion. Pooling reduces individual resource scarcity under normal conditions. It does not remove absorbing states from the healthcare system. Safety under surge requires structural constraints on total demand, not redistribution alone.